So we now begin with question number 71 of our subject-wise test for pediatrics. And question number 71 was, the indication of starting chest compressions in neonatal resuscitation is, and the correct answer is option number B, that is heart rate less than 60 despite effective 30 seconds of positive pressure ventilation. So question number 71, the answer is option number B, that is heart rate less than 60 per minute despite 30 seconds of effective positive pressure ventilation, which is given by an ambu mask. So this is the indication of starting chest compressions, and you should know that if the child has not been intubated till this time, it is better to intubate this child, or it is preferred to intubate the child so as to coordinate the chest compressions as well as positive pressure ventilation. Usually 2 personnel are required when chest compressions are initiated. So one person will give chest compressions and the other person will give positive pressure ventilation. 2 techniques are used. One is 2 thumb technique to give compressions, or 2 finger technique. And further, the chest compressions to ventilation ratio should be between 1:3. The ratio of chest compression to ventilation. And it should be administered for at least 1 minute before the child is reassessed to see whether the chest compressions have been effective or not. So now we come on to question number 72. And question number 72 was, the correct statement regarding rheumatic chorea is, seen in approximately 50% of children with rheumatic fever, usually an early manifestation treated with haloperidol. And the correct answer to this question is option number C, that is treated with haloperidol. So about chorea or rheumatic chorea, you should know that it is a late manifestation of rheumatic fever. In fact, it is so late that it is not essential to have the evidence of previous infection in case of evidence of previous streptococcal infection in case of if rheumatic chorea is present, because it's a late manifestation. It is seen in almost 10% of patients, and it is most common in adolescent females. And it may manifest in the form of emotional lability, poor school performance, and involuntary movements predominantly involving the hands. And the drug of choice or the drugs used for treating rheumatic chorea are haloperidol and phenobarbital. So this was about rheumatic chorea. So now we come on to question number 73. And question number 73 was, incorrect statement regarding white matter injury in preterm infants. And the correct answer is option number B, that is imaging of white matter is easier with predictable results than intraventricular hemorrhage. So this is the incorrect statement about white matter injury in preterm infants. Question number 73, the correct answer is option number B, imaging of white matter injury is easier with with predictability than IVH. So this is the incorrect statement. So we know that preterms are prone to severe complications, and one of the most common important complication that preterms have is of peripartum CNS injury. Which can result in CNS white matter injury. Imaging of white matter is more challenging than imaging of intraventricular hemorrhage. And wide range of white matter injury is encountered in preterms, and they include focal periventricular necrotic lesions, periventricular leukomalacia, and cerebral atrophy. And it is also important to know that this can coexist with grey matter injury as well. So the white matter injury in preterms can coexist with grey matter injury. So next we come on to question number 74, and question number 74 is: an expectant mother undergoes a routine prenatal ultrasound and is found to have severe polyhydramnios. The differential diagnosis of polyhydramnios includes congenital anomalies such as esophageal atresia. Of the following types of esophageal atresia, which is the most common? And the correct answer is option number A, that is esophageal atresia with distal teeth. So esophageal atresia with distal teeth is the most common variety of tracheoesophageal fistula. So now I will just show what are the different types of esophageal atresia. So you see that in type A, there is an upper blind pouch of esophagus, and even the lower pouch is blind, and there is no connection with the trachea. So this is the trachea and this is the esophagus, and there is esophageal atresia without any tracheoesophageal fistula. Next is type B, where there is proximal fistula with trachea, with distal atresia. So there is proximal teeth and distal there is atresia. So this is in type B. In type C, you have proximal atresia of esophagus and a distal teeth, tracheoesophageal fistula. And this is the most common variety of esophageal atresia or tracheoesophageal fistula, which is seen in almost 85% of patients. In type D, there is both proximal as well as distal fistula. So the proximal end of the esophagus also communicates with the trachea, and the distal end of the esophagus also communicates with the trachea. And type E is the H-type fistula, which is sometimes missed at the time of birth and is diagnosed in later life later life, in the sense sometimes at 7 or 8 months when the child presents with recurrent pneumonia. So in that case, this is one of the important differential diagnosis of H type tracheoesophageal fistula, which can be missed at the time of birth, while the remaining 4 types can be easily diagnosed at the time of birth. And this is what we mean by esophageal atresia with distal TEF, which is the most common variety seen in 85% of patients. So next we come on to question number 75, and question number 75 is, the Hardy-Weinberg formula is used for, and the correct answer is to calculate the frequency of the heterozygote or carrier state when the frequency of recessive disease is known. So question number 75, option number D is the correct answer, and that is to calculate the frequency of the heterozygote or carrier state when frequency of recessive disease is known. So this equation is the expression of the principle which states that the amount of genetic variation in a population. So this is based on the premise that the amount of genetic variation in a population will remain constant from one generation to the next in the absence of disturbing factors. And what is this equation like? This equation is p square plus 2pq plus q square is equal to 1. Where p is the frequency of one allele, say allele A, and Q is the frequency of other allele, say A. So this is what the Hardy-Weinberg formula states. This is the principle. This is the principle on which the Hardy-Weinberg equation is based, and this is the equation. So we now come on to question number 76, and question number 76 is, incorrect statement about cerebral palsy with spastic hemiplegia is, and the correct answer is option number A. That is, legs are affected more than arms. So this is the incorrect statement. So in spastic hemiplegia, one half of the body is affected. So it is possible that the right side or either the left side. So the right arm and the right leg would be affected if it is a patient of spastic hemiplegia. And in case of spastic diplegic CP or spastic diplegia, in this condition, legs are affected more than arms. So in hemiplegia, it is one half of the body that is affected. So next we come on to question number 77. Question number 77 was, a 10-month-old infant has dysplastic right external ear, some preauricular tags and a small notch, coloboma, in the iris and the lower lid. Which condition does he likely have? And the answer to this question is option number D. That is charge association. Or charge syndrome. So, what does charge stand for? What does this acronym stand for? In C, C stands for coloboma, which can be present in the eyelids, iris. H stands for heart malformations, which can be either a tetralogy of Fallot or ventricular septal defects. So A stands for anorectal malformations. R stands for growth retardation. G stands for genital anomalies. And E stands for ear anomalies. So this is what the charge association stands for. Now we come on to question number 78. And question number 78 was, a 4-year-old child should require the following amount of calories to be provided by carbohydrates daily in his diet. And the correct answer to this question is option number C, that is 800 kilocalories. So we know that the energy requirement of a 4-year-old child is approximately 1300 kilocalories per day, and carbohydrates provide almost 60% of this energy. Hence this comes out to around 780 or close to 800 kilocalories. So this is the correct answer to this question. So I will just tell you in briefly what is the calorie requirement of children up till 5 to 6 years of age. So the calorie requirement is as follows. So from 1 to 2 years of age, you require around 1000 to 1100 kilocalories per day. From 2 to 3 years, you require 1200 to 1300 kilocalories per day. From 3 to 4 years, you require 1300 kilocalories. And from 5 to 6 years, you require close to 1400 kilocalories per day. So this was about question number 78. Now we come on to question number 79. Question number 79 is, all of the following are acceptable home available fluids for acute diarrhea except. And the option and the correct answer to this question is option number D, that is commercial fruit juices. So we all know that low osmolar ORS has played an important role in reducing the morbidity and mortality from acute gastroenteritis or diarrhea. But in case ORS is not present at home, or if the child is not liking the taste of ORS, there are many homemade fluids as well which can be easily administered to the child so as to maintain his hydration. And what are these homemade or home available fluids? These are salted drinks. For example, you can make lime water with a pinch of salt, sweetened lime water with a pinch of salt. You can give salted chicken soup. You can also use the water that has been used to cook rice with a pinch of salt. You can use yogurt, and you can also use coconut water. But commercial fruit juices and carbonated drinks are strictly not allowed or not recommended for the management or for rehydration in cases of diarrhea, because these drinks have a lot of sugar content, which itself, because of its high osmotic load, can exacerbate the diarrhea. So these are the fluids that are easily available at home which can be used to rehydrate the child. They can be used along with the ORS, and they can also be used if ORS is not available or if the child is not taking ORS. So now we come to question number 80, and question number 80 is, a 12-year-old boy presents with hematemesis melena and mild splenomegaly. There is no obvious jaundice or ascites. The most likely diagnosis is, and the correct answer is EHPVO or extrahepatic portal venous obstruction. So question number 80, the correct answer is EHPVO. So in this question, you were given a clue that this child has no jaundice, there was no jaundice, and there was no ascites, and there was no previous history also. So in this case, with hematemesis melena and splenomegaly, the answer is EHPVO. So you should know that in India, it is the EHPVO is the most common cause of postportal hypertension, almost seen in 50 to 75% of cases. And other uncommon causes of portal hypertension are congenital hepatic fibrosis, non-cirrhotic portal fibrosis, and Budd-Chiari syndrome. So this was about question number 81. Question number 80. So now we come to question number 81. And question number 81 is, extraluminal intra-abdominal calcification may be seen in, and the correct answer is option number C, that is meconium peritonitis. So what are the causes of intra-abdominal calcification? Of course, the first cause, or the most common cause, is meconium peritonitis. Apart from that, hepatic calcifications, enterolithiasis, cholelithiasis, and fetus in fetu are other causes of intra-abdominal calcifications. So, few things about meconium peritonitis. So, if the perforation of the bladder or if the perforation of the bowel occurs in antenatal period, it leads to sterile chemical peritonitis, which is also known as meconium peritonitis, in which case intra-abdominal calcifications may be seen. Now, this condition can be either localized or diffuse and can also lead to a fibrotic reaction. The clinical manifestations depend upon the underlying cause of perforation, the timing, and whether or not this perforation will heal on its own. So the spectrum of disease varies from asymptomatic intra-abdominal calcifications to giant cystic meconium peritonitis. And there can be various associations as well. Associations with meconium peritonitis, and what are these associations? It can be associated with meconium ileus, it can be associated with bowel ileus, it can be associated with intutusception, it can also be associated with gastroschiasis, Meckel's diverticulum, and cytomegalovirus infection. So this is about meconium peritonitis. So it is one of the most common causes of intra-abdominal calcification, and apart from that, hepatic calcification, enterolithiasis, cholelithiasis, and fetus in fetu can also result in intra-abdominal calcifications. Meconium peritonitis can be localized or diffuse. It can lead to a fibrotic reaction leading to calcifications. Clinical features depend upon underlying cause, timing of the perforation, and whether or not this perforation will heal on its own, that is spontaneously. Spectrum of disease may be vary from being asymptomatic intra-abdominal calcifications to giant cystic meconium peritonitis, and meconium peritonitis has also been associated with other conditions like meconium ileus, bowel ileus, intutusception, gastroschiasis, and Meckel's diverticulum and cytomegalovirus infection. So next we come on to our next question, that is question number 82. And question number 82 is, developmental quotient is calculated as, and the correct answer is option number A, that is average age at attainment divided by observed age at attainment into 100. So average age at attainment of that milestone. So DQ or developmental quotient can be calculated for in any developmental sphere, or observed age at attainment into 100. This is how DQ is calculated, and if this is less than 70, it warrants a more further or a detailed developmental assessment of the child. So a DQ of less than 70 warrants further evaluation. Further evaluation, as this is taken as delay. So next we come on to question number 83, and question number 83 is, which of the following statements about natal tooth is incorrect? And the correct answer is usually seen in upper jaw. So this is the incorrect statement about prenatal tooth. So natal tooth, when it appears, is seen more often in lower jaw, and once it has happened, a positive family history increases the chances of further generations also having a prenatal tooth. And further, extraction of this tooth extraction of the prenatal tooth is not seen to affect dentition in later life. So next we come on to question number 84, and question number 84 is, the correct combination is, and the correct answer to this question is option number C, that is telling you about the serum calcium phosphate and alkaline phosphatase in case of chronic renal failure. So in chronic renal failure, serum calcium will be reduced, serum phosphates are increased because there is deficient excretion of phosphate, and alkaline phosphatase is increased. So option number C or CKD or chronic renal failure is the correct, option number C is the correct answer. And what about the other conditions? The correct calcium phosphate levels in the other conditions are as follows. So these are the conditions. So this is vitamin D deficiency, vitamin D dependent rickets, CKD, and Fanconi's syndrome. So Fanconi's syndrome will behave just like proximal RTA. So what happens in vitamin D deficiency? We know that serum calcium is reduced, serum phosphate is also low, and alkaline phosphatase is increased. While in vitamin D dependent rickets, serum calcium is reduced, this is reduced or normal, and alkaline phosphatase is increased. While in CKD, serum calcium is reduced, phosphates are increased, and alkaline phosphatase is also increased. While in Fanconi's syndrome, we see that the calcium is normal, the phosphate is reduced, and the alkaline phosphatase is increased. So these are the correct combination of other conditions that are given in this question. So next we come on to question number 85. And question number 85 is clinical criteria for streptococcal toxic shock syndrome involves all of the following except. And the correct answer is option number B, that is myositis. So what is the criteria for diagnosis of streptococcal toxic shock syndrome? I will just tell you about that. So there is a clinical criteria, and what this clinical criteria involves presence of hypotension, plus presence of any of the following two characteristics. And these are either renal impairment, coagulopathy, hepatic involvement, acute respiratory distress syndrome, generalized erythematous rash, and when do we say it's a definite case? Definite case is said with these if the clinical criteria is satisfied, plus there is evidence of streptococcal infection. So this is how cases are defined in case of streptococcal toxic shock syndrome. So you have clinical criteria and you have criteria when to call a case as a definite case of streptococcal toxic shock syndrome. So next we come to question number 86. Question number 86 is straining and dribbling of urine in male infants with history of recurrent UTI should strongly indicate, and the correct answer is option number B, that is PUV or posterior urethral valve. So these symptoms that were given to you in this question of straining and dribbling, they indicate obstruction, and in males posterior urethral valves are one of the most common cause of obstruction, and hence this is the correct answer. So now we come on to question number 87, and question number 87 is PUV is diagnosed on micturating cystourethropography by, and the correct answer is dilatation of prostatic urethra. So we know that PUV is one of the most common causes of obstructive uropathy in male infants, and a MCU or a micturating cystourethropography is one of the most commonly used investigative procedure to diagnose PUV, and in this micturating cystourethropography you can see that there is obstruction at the level of virumeonetum, which will lead to dilatation of the prostatic urethra. Which will be picked up in a MCU, and this is similar to the finding of a keyhole sign which is seen on ultrasonography. So if an ultrasound is used to diagnose PUV, then it will be the keyhole sign, and if you are using MCU to diagnose PUV, then it would be the dilatation of prostatic urethra, which will help you to make a diagnosis of PUV. So next we come on to question number 88. And question number 88 is, under 5 mortality rate may be expressed as a sum of, and the correct answer is option number A, that is IMR plus child mortality rate. So under 5 child mortality rate is a sum of IMR, that is infant mortality rate, plus child mortality rate. So under 5 mortality rate refers to the probability of children dying before 5 years of age per 1000 live births. So this is also expressed as a sum of infant mortality rate, which is the probability of children dying before their first birthday per 1000 live births. It is under 5 mortality rate is also an appropriate indicator of cumulative exposure of risk of death during the first 5 years. And what are the common causes of under 5 child mortality? Well, the important causes of under 5 child mortality are pneumonia, diarrhea, malaria, and measles. So these are the important causes of death in under 5 children. So next we come on to question number 89. And question number 89 is, in pellagra, demyelination of which columns of spinal cord takes place? And the correct answer is option number B, that is posterior and lateral columns. So a few things about pellagra. Now pellagra, the manifestations of pellagra are described by 3 Ds. and these are diarrhea, dermatitis, and dementia. So, the GI symptoms in the gastrointestinal tract, we see that there is a rapid turnover of cells. So, it is the gastrointestinal system that first shows manifestations in the form of diarrhea, which can occur because of intestinal inflammation. And this diarrhea is typically watery and does not have mucus or blood. So, children with pellagra will also have poor appetite. Amongst the GI symptoms, they will have poor appetite, they will have nausea, cheilitis, glossitis. They will also have gastritis, and the walls of the colon may be seen to be inflamed and thickened. In the skin, usually the initial manifestations may be erythematous, but in some cases there may be formation of bullae as well, in which case it is also called as wet pellagra. Usually the lesions are often symmetrical and are seen most often in the areas exposed to the sun. So the dorsum of the hands and feet, the neck area and the malar area are most often affected with the dermatitis that results due to pellagra or vitamin B niacin deficiency. While in the CNS, these symptoms usually occur late in the disease, and they include patchy areas of demyelination. And along with demyelination, there may also be degeneration of ganglion cells. This demyelination is seen more commonly in the posterior and the lateral columns of the spinal cord. The patients may have poor concentration, they may have depression, they may have anxiety, they may be irritable, and as the disease progresses, patients become disoriented, they become stuporous and ultimately comatose. So this is about pellagra. So we see that three major systems are involved. It is the GI tract, the skin and the CNS. And in GI you have diarrhea, you have poor appetite, nausea, cheilitis, glossitis with gastritis. In the skin, they may the symmetrical areas exposed to the sun may be involved. Usually the lesions are erythematous, but bullae formation may also be seen, in which case it is called wet pellagra. In CNS, the CNS manifestations occur late in the disease. There are patchy areas of demyelination which are commonly seen in the posterior and the lateral columns of the spinal cord. There is degeneration of ganglion cells as well. Patients may present with poor concentration, depression, anxiety and irritability, and as the disease progresses, it is seen that the patients are disoriented, they become stuporous and comatose. So next we come on to question number 90, and question number 90 is false about febrile convulsion is, and the correct answer is always occurs with high temperature. So this is the false statement about febrile convulsions. So actually the febrile seizures do not occur always with high temperature, they basically occur with the abruptness of the rise of temperature. So there are few salient points that you should know about febrile seizure in children. So what are these points? First, you should know that they are commonly seen in children from 6 months to 5 years of age, commonly seen with the abruptness of the rise of fever. They are classified as simple or complex or typical or atypical. We say they were typical if they occur within 24 hours of onset of fever, if they last less than 15 minutes, and if the child is fine, playful after the postictal period has waned off. While in complex or atypical febrile seizure, if the seizure episode occurs either after 24 hours of onset of fever, or if there are multiple episodes which occur during the illness period, and if it is associated with status, or if the duration of fever is more than 15 minutes. So what are the points in typical? So for typical, they usually occur within 24 hours of onset of fever. There is a single episode within the illness period. Usually the seizure is GTCS type. The typical febrile seizure will be GTCS type, and the duration will be less than 10 minutes. So it is of lesser duration. It will never be, a typical febrile seizure will never be associated with status. While in atypical febrile seizure, they can even occur after 24 hours of onset of fever. Multiple episodes can occur in a single period of illness. They can be focal and they can be prolonged. So this is about atypical febrile seizure. Usually a patient who has a typical febrile seizure, they need not get, or they need no indication of LP or imaging, that is CECT. So there is no indication of LP, imaging or EEG in a typical febrile seizure, but one should consider getting a LP if the episode of febrile seizure occurs for the first time in a child who is less than 1 year of age, and that is because in this age group the signs of meningitis or the meningeal signs are not very forthcoming. So it is difficult to say that the child may not have meningitis. So it is essential that if a child less than 1 year of age has come with the first episode of febrile seizure, then we should get a LP. Otherwise, in a well child, there is, and if he is beyond 1 year of age, and if he has already had episodes of seizures along with fever, then there is no indication of doing a LP, imaging or EEG. Further, if there is already a family history of seizure disorder, then in such children there are risk of developing epilepsy in later life. But if there is no such history, then often these children will outgrow of these seizures. So this was about febrile seizures. So now we come on to question number 91. And question number 91 is, a 2 hours full term newborn infant noted to have episodes of cyanosis and apnea in nursery. When the nursing staff attempted to feed him, his oxygen level dropped to 60s. When he is stimulated and he cries, his oxygen level increases in 90s. Which of the following is the most important next step to be done to establish the diagnosis? And the correct answer is option number D, that is passage of catheter in the nose. So what is this condition? So you see that this is a newborn who has just born, and his SpO2s are falling when he is being fed, and when he cries his oxygen level increases. So basically it is a case of choanal atresia. So it is a case of choanal atresia. That means the bilateral choanae are blocked. So when you are attempting to feed this child, since the choanae are blocked and the child is now a mouth breather, because of the feed that is in his mouth, he is unable to breathe, and so he becomes cyanosed. And when he cries, he opens his mouth, his SpO2s begin to rise again. So this is a typical history which comes in the case of choanal atresia, and by passing a catheter in the nose, which will not be easily passed, there will be an obstruction that will be felt, will help you to make a provisional diagnosis of choanal atresia. So the correct answer to this question was option number D, that is passage of catheter through the nose. This choanal atresia may be associated with charge syndrome that we have already discussed in one of the previous questions, where it can also be associated with colobomas, heart anomalies, anorectal malformations, growth retardation, genital anomalies, and atresia, choanal atresia, and ear anomalies. This condition is also commonly seen in children who have mid-facial hypoplasia. So this can also be seen in conditions like conditions associated with craniosynostosis. So it may be associated with Cruzen syndrome. So because of the mid-facial hypoplasia and other abnormalities of the nasal bridge, these patients may also have choanal atresia. So this may be seen in Cruzen syndrome. So now we come on to question number 92. And question number 92 says, expressed breast milk can be stored in freezer for how long? And the correct answer is option number D. That is, expressed breast milk can be stored for over 1 month in a freezer, and it can be stored for 24 hours in a refrigerator. So if you are storing it in the refrigerator, it can be stored for 24 hours. If you are storing it in the freezer, it can be stored for over 1 month. Question number 93. Now we come on to question number 93. And question number 93 is, which of the following is not to be done in a case of a mother with tuberculosis who delivers a baby? And the correct answer to this question is give ATT for 2 years. So option number C is the correct answer. So this is something that we are not supposed to do. Give ATT for So a mother who has tuberculosis delivers a child, then there are some points that you need to remember. So if the mother starts the treatment before the child is born, then it is less likely that the child will acquire tuberculosis in the postnatal period, because the sputum will become sterile if the mother has been taking ATT regularly. However, it is important to rule out congenital tuberculosis in this child. Because in congenital tuberculosis, disease may have also been transmitted through the placenta. So in this case, disease has to be ruled out. And once TB has been ruled out, if TB has been ruled out, that is, if the child is well, then there may be an indication of giving INH prophylaxis to the child. So basically there are two things. If the mother has had tuberculosis during her pregnancy, then we need to see whether the child is affected with TB or not. If he is affected with TB, by doing various investigations like ultrasound, doing a gastric aspirate, if we rule out tuberculosis, then we give him INH prophylaxis, that is, we give him isoniazid in a dose of 10 mg per kg per day for a total duration of 6 months. While if the child is found to have disease, then he will receive ATT for the stipulated duration, that is 9 months. Some authors do say that one should separate the child and the mother, but there is a lot of controversy with regard to this. But many authors do agree to the point that once ATT has been started, then the child and the mother should not be separated and the mother can still continue to breastfeed. So now we come on to question number 94, and question number 94 was Antley-Bixler syndrome. All of the following are seen except, and the correct answer is option number D, that is absence of radius and ulna. So what is the Antley-Bixler syndrome? So this is a autosomal recessive disorder which occurs due to deficiency of cytochrome P450 oxidoreductase enzyme. And the clinical manifestations include craniosynostosis, brachycephaly, choanal stenosis, Humeroradial synostosis, medial bowing of ulna, anterior bowing of femurs, long slender fingers, and narrow iliac wings. So basically humeroradial synostosis is seen, and hence the correct answer was absence of radius and ulna. So now we come on to the next question, that is question number 96, and question number 96 was, infants with aldosterone synthase deficiency have all of the electrolyte abnormalities except, and the correct answer is option number D, that is metabolic alkalosis. So, the electrolyte abnormalities that are seen in aldosterone synthase deficiency are as follows. They are as follows. So, there is hyponatremia, because there is aldosterone deficiency. There is hyperkalemia, there is metabolic acidosis, there is low or undetectable aldosterone levels, and normal cortisol levels. Along with that, there is raised plasma renin activity. So these are the salient abnormalities that are seen in patients with aldosterone synthase deficiency. So there will be hyponatremia, there will be hyperkalemia, metabolic acidosis. Along with that, there will be low aldosterone levels, normal cortisol levels, and raised plasma renin activity. So next we come on to question number 96. And question number 96 was, following is a feature of lower urinary tract hematuria, and the correct answer is option number B, that is terminal hematuria. So in this question they were asking about differences. In this question you were supposed to know the differences in hematuria that results from upper urinary tract and lower urinary tract. So hematuria from upper urinary tract results if it comes from upper urinary tract hematuria would be seen if the hematuria originates from the nephron, anywhere from the glomerulus, the collecting or the convoluted tubules, and the interstitium. While the lower urinary tract, if there is hematuria from the lower urinary tract, hematuria may originate from the pelvocalyceal system, the ureter, the bladder, or the urethra. So basically it is the hematuria that comes from, or the hematuria that originates in the glomerulus, which is associated with cola colored urine and protein of more than 100 milligram per deciliter. And if you see a urine microscopy, you may also find dysmorphic RBCs. So these are few salient points. So you should know when is hematuria coming from the upper urinary tract. If it comes from the pelvocalyceal system, the ureter, bladder, or the urethra, then the hematuria has originated from the lower urinary tract. And if the hematuria is glomerular hematuria, which is again classified under upper urinary tract, then there would be cola colored urine, there would be protein would be more than 100 milligram per deciliter, and there would be dysmorphic RBCs on urine microscopy. Next we come on to question number 97. Question number 97 is a 2-year-old child with a known history of rheumatic heart disease presents with 3 weeks history of fever with palpitations. The most likely cause is, and the correct answer is option number C, that is staphylococcal endocarditis. So this condition, you will make a diagnosis of infective endocarditis, because if there is any underlying heart disease and if there is new onset of fever, if there is new onset of a new murmur, then infective endocarditis is to be considered as the first differential diagnosis. And because staphylococcus is the most common organism that causes endocarditis, in this question the correct answer is staphylococcal endocarditis. So next we come on to question number 98. And question number 98 was, all of the following are features of fetal alcohol syndrome except, and the correct answer is option number B, that is hypertrophied philtrum. So fetal alcohol syndrome is seen in children whose mothers have consumed alcohol in pregnancy, and it is characterized by microcephaly, hypoplastic philtrum, and it is not hypertrophied. So it is hypoplastic philtrum, hypoplastic upper lip, and they also have feeding problems and disorganization of neurons. So in fetal alcohol syndrome, you will have hypoplastic philtrum and not hypertrophic philtrum. So the correct answer was option number B. Next we come on to question number 99, and question number 99 was a image based MCQ, and you were asked to identify these white lesions present on the neonatal palate, and the correct answer to this question was option number C, that is Epstein pearls. So if you see in this image, you see these whitish lesions here on the palate. These are Epstein pearls which are seen in the newborn, and these are the few that are classified under common parental concerns apart from melia and erythema toxicum. So Epstein pearls are whitish to yellowish. They are whitish to yellow cysts that are present commonly on the heart palate of well newborns. Similar whitish spots may also be present on the face when they are called melia. And from day 2 to day 5, often erythematous maculopapular rash may also be seen, which is known as erythema toxicum, and usually if smears are made from these lesions of erythema toxicum, you can find abundance of eosinophils. So these are normal findings that are commonly seen in normal newborns. Epstein pearls, melia, erythema toxicum, they are all self-limiting features and nothing needs to be done about them. So now we come to question number 100, and question number 100 was, drugs which give rise to galactorrhea are, and the correct answer is option number D, that is all of the above. And in this you see the options that you had were amitriptyline, reserpine and metoclopramide. So what are the drugs that cause galactorrhea? There are many drugs that cause galactorrhea, and in fact metoclopramide that is mentioned here is also used sometimes to induce lactation in mothers who have problems with lactation. So the various drugs are, apart from the drugs that are mentioned in this question, so amphetamines, cimetidine, estrogens, haloperidol, methyl dopa are other drugs that can cause galactorrhea. So these are the few drugs that also cause galactorrhea apart from the drugs that are mentioned in this question.